So today we'll talk about Kaposi Sarcoma, which is a very common cancer in our region. It's a very quick lecture or tutorial, as it were. So if you answer the questions, you can easily be done within 45 minutes. So these are the objectives for this week and next week. They'll look the same: defining the cancer, classifying the cancer, who is affected, how do you end up getting it, how does it look like, how do you investigate, staging the cancer, and how do you... Hello? Is there someone trying to speak? Okay. So we'll start by first defining it. And I've written there angioproliferative low-grade malignancy caused by human herpes virus number 8, originating from the lymphatic endothelium. So basically, the cancer causes proliferation of lymphatic vessels. It's caused by infection by the Kaposi Sarcoma associated herpes virus, and it's low grade. By low grade, we mean that it looks like normal cells and tends to grow slowly and spread slowly compared to the high grade ones. Yeah, so it's locally aggressive. So where it will cause issues mainly where it starts growing. It will not. It will rarely cause distal problems. Okay, so when you're classifying them, there are these 4 types. We have the classical, you have the endemic, you have the immunocompromised, and then you have the epidemic. So most of the time, we never used to have a lot of Kaposi sarcoma until HIV happened. And then now we ended up with this epidemic one, which is associated with HIV. So when you're talking about the classical one, it tends to affect the individuals in the Mediterranean region, affects mostly men in the middle age. So what do you call this? For the endemic one is the one now we see in Africa, especially the central region of Africa. And that one is not associated with HIV. It was there before, and it's seen both in children and in middle-aged individuals. Okay. It's seen quite a bit, especially in our neighbors here in Uganda. So that's why you might be able to see these two. Just to remind you that we have the African cutaneous and the lymphoadenopathic Kaposi sarcoma for the endemic one. The immunocompromised is iatrogenic. So it comes to about in patients who we give drugs to lower the immunity, especially after transplantation. So it happens maybe a year or 3 years, 1 year to 3 years after you've done the transplantation. These cancers tend to arise. And one drug that is notorious for that is sirolimus. So that tends to cause that immunosuppression and the Kaposi sarcoma. Epidemic, as I've mentioned, has just started because of the HIV prevalence and incidence that has been rising, that had risen before, and the fact that it has affected and plagued this African region. So when you're talking about the epidemic, you tend to have a lot of visceral involvement. Most of the time, the Kaposi sarcoma will just affect the mucocutaneous region, but when it starts becoming visceral, then we have bad prognosis. Okay, so the epidemic one is known for being for having that bad prognosis, and also the endemic one, when you're talking about now lymph node involvement. When you're talking about viscera, you're a bit more worried. Okay, also the immunocompromised. Okay, so those ones we are a bit more worried in terms of the prognosis because they involve the viscera. Okay. So again, just to mention again is that the epidemic one is it's an AIDS associated cancer. So if you see this, then you know that the patient is already in acquired immunodeficiency syndrome. So when you're talking about who is affected, as I mentioned before we never used to see a lot of this until a lot of people started becoming immunocompromised and the HIV prevalence started rising. So you see the epidemic one with HIV patients, you see the iatrogenic one with transplant patients, and you see the endemic one in the central region. Okay, and the older Mediterranean Jewish people will have the classical type. This does not mean that you'll not see it in Africa. Okay, you can still see these types because again, it causes around 5% of all malignancies in Kenya. So you also expect Kaposi sarcoma. So how do we end up with this Kaposi sarcoma? Um, so usually it's you have to get an infection with herpes 8 virus, or the Kaposi sarcoma associated virus, which is usually spread sexually or via fluids. Okay, so the Kaposi sarcoma itself does not result from like neoplastic transformation of cells, but rather results in excessive proliferation of spindle cells of vascular origin. And in this case, we talked about lymphatic endothelial cells, which are CD4, 45 positive cells. Okay. And what do you call this? So it usually, when it infects the cell, it has two phases. You have the lytic phase and the latent phase. So in the lytic phase, the virus itself induces destruction of the cell, so it breaks out, and then it can spread more within the internal milieu. Okay, and in the latent phase, it doesn't replicate as much. It doesn't replicate at all. And in this particular situation, the virus is now going to start expressing proteins that allow it uh, to stay within the cell for a longer period. Okay, and in this phase we usually call it what do you call this? We call it the latent phase. All right. Uh, so it starts to express viral episomes. I don't know whether you guys know what that is, but it's usually a component of the genetic material of the virus that is produced independently. Okay, and sometimes can even become integrated um, into the cells. Okay, so we have these latent associated nuclear proteins, nuclear antigens, which cause oncogenic dysregulation of cellular functions, pathways. In this particular case, what you're going to have is the tumor suppressor pathways are disrupted. Okay, so that is P53 and retinoblastoma gene. Those ones are disrupted. The P53 is usually the gatekeeper of the cell. So by that means that whenever your cells are replicating, it confirms that the DNA is normal and the DNA has no issues. Okay, and if it does, it causes the cells to die, apoptosis, or it causes the reduction of proteins, which we call cyclin, for example, cyclin D, which is important for the continuation of the cell cycle. Okay, and at the same time, uh, it also stimulates now the cells to repair that DNA. Okay, so when this protein is there and it starts being produced, we have dysregulation of that tumor suppressor pathway together with the retinoblastoma pathway. So the retinoblastoma also does the same thing. It's associated with a protein called E2F. Um, no one will ask you this, by the way, but it's just good to know that it's associated with tumor suppression. Okay. So when that happens, there is increased proliferation. At the same time, this virus is causing the increased production of vascular endothelial growth factor, and this in itself results in increased proliferation. At the same time, uh, we have increased cytokine production, and this, it's like a vicious cycle, increases the proliferative milieu in the cell. So when you have HIV, which is not now related directly um, this is if you're going to be asked about the epidemic. This you can add this statement and say, when HIV is there, it promotes the proliferation of the herpes virus by indirectly impairing the immunity. So now your cells can easily be infected. At the same time, directly increasing the proliferative milieu by increasing the amount of cytokine that is being produced. All right. So the last 2 points basically emphasize the role of excessive proliferation in Kaposi sarcoma. Okay. So you have these three phases. You have the patch, plaque, and nodular phase. And last week we went through these terms and what they mean. So we'll not go through them again. So the hallmark of patch is basically angiogenesis. And then plaque basically is inflammation. So you have an increased density of inflammatory cells. And then in the nodular one, now you have proliferation of, uh, of spindle cells. So this one is the first phase, and this one is the patch stage. And what we are seeing here is vessels now protruding, which is this you guys can see on your end. You have vessels now protruding into the new vascular space. And this one, it's usually called the promontory sign when you see this entering this space. Okay. The next one is the plaque phase. And in the plaque phase, you have um, and you have like large hyaline deposits within the cells, which you can clearly see in this particular case. And it causes a sign called autoillumination. So you can see through them. Okay, so you have paranuclear vacuoles. As you can see the nucleus and then it's clear, right? So that's the second phase. The third one is the nodular one, where now you have spindle cells. You can clearly see them. And inside here is the blood vessels. Within each, you have blood contained inside them. And in this particular situation, the tumor has become a solid nodule. You can see morphogenic spindle cells, which are slit-like, multiple of them, you can see, especially this region. And then in this particular case is when now you'll be able to even identify the herpes 8 virus in the cells if you do histochemistry. Okay, so the proteins that you're looking for is the LANA 1 and the LANA 2, but most of the time they do the LANA 1, which you've explained what their role is. How do these patients tend to present? These patients, they have lesions everywhere except the CNS. Okay. But most of the time you'll have issues on the skin, and that's why now plastic surgeons are involved. But you can have the oral mucosa where you can get the maxillofacials, and GIT where you might have to involve the general surgeons. Okay. But you can have lesions basically everywhere other than the CNS. Does someone want to tell me why? Why do they think we have lesions everywhere other than the CNS? Doris Kilonzo, why do you think we have lesions everywhere other than the CNS? Is Doris with us?
Yes, I'm with you.
Uh-huh. Do you know why?
No.
Huh? Do we have lymph nodes in the brain? Do we have lymphatics in the brain?
No.
Maybe that could be one of the reasons. Okay. So we have these lesions could be macular. We talked about what a macule is. Could be nodular, and it could ulcerate. All right. So what we are seeing here are those lesions that we're talking about. Okay. So sorry. Here we have this epidemic Kaposi sarcoma in AIDS. You have macules, pigmented macules, which are they say they are violaceous. That's the right word. Okay. Which means basically purplish violet color. Right. This one is nodular, classical, seen in an African, where you're seeing nodules appear on the back of the leg. Okay. Again, this one is the same. This is the endemic one, which we see it again in Central Africa. And in this particular case, you can see the warty appearance with hyperkeratosis. Okay, so you can see these cutaneous lesions on this patient. I'm sure you've seen this in the world already. GIT, you see this, sorry, 1 second. So in GIT, they tend to, most of the time, they're not symptomatic, they are symptomatic, but then if you do an endoscopy, especially now when they start having diarrhea that is not being treated, that is not well controlled, and then you're having bleeding, protein losing enteropathy, you start having intestinal obstruction and all those things, then you might see these polypoid nodules, which again could be very red. Sometimes you could also have these violaceous nodules in the hard palate. Okay, and they're usually hard and tender, and some even on the gums. Okay, respiratory is the same story. They may be asymptomatic and might even be an accidental finding when you do a chest X-ray. But again, they could have dry cough, pleuritic chest pain, hemoptysis, fever, difficulty breathing, respiratory failure, upper airway obstruction. Okay, because of the polyps. So when that happens, now it's already advanced, but most of the time you tend to find it. What do you call this? Accidentally. Okay, so you might have to do a HRCT, which I think you're very familiar with, especially with the COVID pandemic, to be able to identify these nodules, okay, and opacities. So when you're talking about lymphedema, we have lymphadenopathy again, because straight into the lymph nodes, and then you have this lymphedema, which is basically accumulation of fluid outside of the vascular space. And as you can see here, this patient has nodules. This was a HIV patient. You can see they have nodules and they still have the edema. This child has the preauricular, postauricular, this what are they called? Forgetting the name. But you have the upper cervical lymph nodes are already enlarged, and the occipital lymph nodes are enlarged. So they're bulging lymphadenopathy, which are seen in classical Kaposi sarcoma. Okay. So a question I have for you guys is, how do you usually classify, or how do we usually grade um, lymphadenopathy? Or lymphedema, that's the right word. Anyone want to try? How do we grade lymphadenopathy? Okay, I think that's something you can go check up on your free time. There's something called the Cheng lymphedema grading system, where we start from 0, where basically you don't have much symptoms, to all the way to 4, where you have very severe symptoms and you might have to do a lymph node transfer. So just check up on that on your free time. It's called the Cheng lymphedema grading system. Okay, so it's important, especially when you're talking about these patients. Do you want to transfer lymph nodes to that area or not? So those are the questions you might be asked if you're doing very well in the exam. So the next is, how do we now confirm? And this is now an area that I now want to engage you guys. How do we confirm that a patient has Kaposi sarcoma? Because we've talked about the 4 variants. Do they look different? No, they all look the same histologically. And we've already talked about which ones they are, the 4 of them. So how do you biopsy? What type of biopsy do you do? Mhm. Gitao Nyambura, how do you biopsy this Kaposi sarcoma? How would you biopsy for us to be able to do histology?
I think it would be an excisional biopsy.
An excision biopsy?
Yeah,
Will you be able to remove all this?
just one. You remove just one.
Okay. All right. So what is that called when you're just removing part of the entire lesion?
Incisional biopsy.
Yes. So we tend to do an incisional biopsy. That's usually the standard, because you can't remove the whole thing and it's interconnected. Yeah. Maybe these lymph nodes, yes, maybe you can remove one lymph node, but most of the time you'll do an incisional biopsy. You can do a PCR on it for the human herpes virus. Do some immunohistochemistry, as we talked about before. And then, so those are the special tests you might want to do. You might do a PCR on it. You might do HIV screening. Yes. So you have to do the antibody test. The confirmatory tests you can want to do, like the ELISA test, CD4 counts, and the viral count. Is it viral load that you do, especially in our setup where most of the time it's associated? Okay. Which imaging would you request for? Joseph Kisavuli, which imaging would you want to do for these patients? And why? Why would you want to do that particular imaging? We've already seen some.
Chest X-ray or a CT test to rule out a possible pulmonary Kaposi.
Yeah. Yes. That's good. Any other tests that you might want to do in the chest?
You could do bronchoscopy and
If you're going to do a bronchoscopy, you might also want to do an OGD as well, Sindo, so that you look at the GAT. Anything else that you want to do? So you might want to do a PET scan for the lymphatics. So this is related again to the question I just asked you before, about the Cheng's classification of lymphedema. So you want to see whether there's any obstruction in that lymphatic system. Okay, so it's called a lymph scintigraph. Okay, so you'll be able to see whether there are any obstructions in the pathway of the lymphatics because of disease or any obstruction. Okay, so that's very important, especially with this lymphedema. So in that particular case, that was grade 5 lymphedema. So you definitely would benefit by doing it. If you're in a setup that can do it, like Aga Khan, why not do it? Okay. So we've talked about the diagnostic procedures, the bronchoscopy, OGDs. Yeah, that's basically all you might want to know. So how do we stage it? So far there's no acceptable official staging system. And you might find that different setups, like different hospitals, tend to have their own classification. Like this place creates its own, this place creates its own. While it's not widely accepted. So it depends now on the particular type. So there are some which have been proposed, like especially for for the classical. In the classical, you have stage 1 to 4, and they've given them names based on how they appear. So you have the macronodular, where you have just very small macules and nodules, especially in the lower extremities. And then you have the infiltrative. So in this particular case, you have very few nodules, but more of plaques. So now it's trying to get deeper. And then you have stage 3, where now you have angiomatous plaques with nodules involving the extremities that are often ulcerated. Okay, so this is the florid stage, and then you have the disseminated. So now these ones are beyond the lower limbs. Okay, so when you're talking about these stages, in this particular case, stage 1 to 3 are divided into 2 groups. Group A is usually slow growing, and then group B are rapid disease progression. Okay, so that means that the plaques and the nodules are increasing in number at a very fast rate, especially within 3 months of follow-up. Okay, but all patients who are in stage 4 have rapid progressing disease. This one is more, not I wouldn't say more important, but this one is important because at least this one, even if it's proposed, it tends to be used a lot, especially in our setup. So where you group a patient into a high risk or a low risk, a good risk patient or a poor risk patient in terms of management, and you look at the tumor, you look at where the tumor is, the characteristics of the tumor, you look at the immunity, and then you look at the systemic illness. Okay, in this particular case, like for example, the tumor is found only in the skin, minimal oral mucosa and lymph nodes. Okay, but in this case, when it's a poor risk, you just need one of them actually, unfortunately. Listen, you have to have all of it. You have edema, ulceration, extensive oral mucosa involvement, visceral, Kaposi Sarcoma, and I said visceral, you already have issues, okay? When you're talking about now the CD4 count, this one is more than 150, this one is less than 150, the poor risk. And then when you're talking about the systemic illness, do they have constitutional symptoms? And those are the B symptoms. If they don't, then they're in this group. If they do, then they're on this other side. Okay. Any opportunistic infection, then they're in the other group. Okay, because now we are worried. Now we are entering into AIDS. Okay, do they have any HIV related illness like neurological disease and lymphoma? If they do, then they're in the poor risk group. So you have the Karnofsky performance status scale, which is basically used to tell us how good or how dependent is this patient of ours. Okay, how able are they to do their own thing without requiring much assistance from everyone. Okay, so majority of us are in like 100%, maybe a few of us might be 90, but majority are in 100%. So when you're at 70, it basically means you're able to perform ordinary tasks without much assistance. Okay, so that means you can take care of yourself without really needing a lot of involvement from other people. But if you're less than 70, then you're not ambulant. You need a lot of assistance to do just basic life related events. Okay, so this is how it helps when you can categorize patients. Unfortunately, if you have any one of these on this side, the patient is pushed to the poor risk. And when they have all of these other ones, then they're in good risk. Okay. So now we get to the fun stuff, which is how do we treat these patients? Unfortunately, in our setup, they tend to come a bit late. They tend to allow disease to progress because as we've seen is locally aggressive. So it should be easily treated, but it is. But you tend that sometimes you find yourself in a situation where it's more of palliation. You're preventing the disease from getting any further. You're trying to reduce the edema. So basically you're just palliating the patient. Okay. But in the case where you get a patient coming in early and you're lucky, okay, you now find yourself in this local systemic treatment, which is ideal, the good risk patients, okay. And what do you call this? So when you're talking about local modalities, there's the surgical, which we'll talk about later, but there is a interlesional chemotherapy that we tend to give. There's vein blasting, but we still also have doxorubicin and duan. I can't remember the other one, but it starts with the D. But those are the ones that we tend to use in our setup, especially doxorubicin. Those are the ones we tend to use for intralesional chemotherapy. Then you have radiation therapy and topical like vitamin A gels, which is what we tend to give in local systematic treatment, and it works out very well. So the unfortunate thing is that even when you do this such local systemic treatment, is that um, you don't prevent development of new lesions. So you have to be aware of that even when you're doing the intralesional chemotherapy, which are a bit pricey. Okay. For systemic, now these are the patients who are now going to the poor risk, especially if this is in related to the epidemic Kaposi Sarcoma. And also at the same time, when you have what do you call it, rapidly progressing, now you're getting to stage 4, then you tend to do the systemic therapy, okay. And in this case now you have, oh, the other drug I was trying to remember was this one, duanorubicin. So these are the ones that we tend to give. This is second line, the pomalidomida. I hate these words anyway, but this is the one that we give a second line, okay. So heart is reinitiated for these patients. We don't have to wait for those 2 weeks grace period. If they do have HIV, then we do start them on heart in either of the cases, okay. For surgical role, we do excision, wide local excision of the tumor to try and have local tumor control. This goes back to what we learned last week and how to manage them. And how to manage them. We talked about how to deal with small lesions, which appear benign. So this one is malignant, but it's the similar way we deal with them, okay. So curettage of these small lesions is usually followed by hydrogen peroxide. This is mainly to stop the bleeding, okay. Yeah, that's basically it. That's mostly what I wanted us to know. There's one concept that is important for us. Maybe I did not put a slide on, is how do we evaluate uh, uh, the what do you call this? How do you evaluate tumor that the tumor has responded to treatment? Okay, I don't know whether anyone is aware of that before I say it. How do you evaluate? Because we have basically like 4 categories, whereby you have patients who will respond very well. Okay, so those are the responders, and then you have patients who will respond but barely. Then you have patients who, when you even start the treatment, it gets worse. So that's progressing, and then you have either or. So in this particular case, it's not progressing any further, or it's not reducing. So it's as if the treatment is not doing anything. Okay, so we have those four categories, and it's mostly used for HIV patients. So again, this one was started by the HIV clinical trial group, which gave us the classification that we just saw. So they have a way of confirming that this person is a responder, partially a responder, and the in between, and those ones with rapid progression. Okay, so I didn't put it here, but it's something that would be good for you to know. But it's in our national guidelines. So maybe we can answer this question quickly. Are you guys seeing the question? Okay, good. Okay, I'm seeing majority of you guys got it right. So it tends to come from lymphatics. So yeah, guys, that's basically it. That's majority of what you need to know for the Kaposi sarcoma. If there's anything that that you not understand, maybe you can ask. But that's basically it. I would highly recommend that you check out this too. You have Kaposiform hemangioendothelioma, which is a differential for Kaposi sarcoma. Check out how it appears and how is it different from Kaposi sarcoma. You have bacillary angiomatosis, which is a bacterial infection by Bartonella. So you can check out how to differentiate the two. There's a special test that we do to differentiate the two, to now know that this is not Kaposi sarcoma that you're dealing with, and it's the bacterial infection. Okay, so these are things that might help you out in the future, especially if you end up not working in our region. Okay, so yeah, that's it, guys. Kuna swali?
Yeah, I have a question.
Okay.
Could you please clarify the origin of the Kaposi sarcoma lesions? Because you said they mostly infect spindle cells of vascular origin, but on the question on why they don't infect the CNS, we said it's because there's no lymph node. So is it that the spindle cell is lining both blood vessel and lymphatic vessels? And also that where does the CD45 come in?
Okay, good. So the what do you call this? The herpes itself, the herpes 8 infects lymphatic vessels. Okay, so it's not just vessels, the endothelial vessels. And the endothelial vessels tend to have a protein, which is now CD4, CD45 positive cells. Okay, so that was just for immunohistochemistry, but most of the time that's the cell type that they tend to infect. It just so happens, it just so happens that the lymphatic vessels, the endothelium that makes up the lymphatic vessels has CD45. Okay, so you don't find lymphatics in the brain, and that's why we don't tend to get Kaposi sarcoma of the brain. Hope that has clarified everything.
Yes, it has.
Okay, so,
Good evening.
good evening.
Could you please repeat how you divided the responders to treatment into 4 groups?
Oh. Okay. So you have, let me see whether I can get that. Where should I put that thing here? You have the ones that respond very well. I think I put a link. Just 1 second. There's a link I put for the document. There are those that respond very quickly to, or respond well to Kaposi sarcoma treatment, whichever, if it's chemotherapy or whatever it is that you're doing. So they're responders. So those ones, you have the lesions completely disappearing. And then you have the partial responders. So that is within, I think, a period of 3 months, there's a response. So the lesions have reduced in number and size, but not completely. So those are the partial responders. Okay. Let me just get to. You able to see my screen?
No.
Perfect. I'm sure you can see now. Able to see?
Yes, see it. Yeah, we can see it.
Okay. So these are these are Kenya national guidelines for the treatment, and this is some of the things that I was trying to tell you. This is like how to decide how to treatment. So the last part talks about how to evaluate if they are responders or not. Okay, so you have the ones who completely respond to treatment. Okay, so there's in this particular case, they would define it as absence of detection of the lesion, including tumor-associated edema for more than 4 consecutive weeks. Okay, so that's the exact definition. And then for the partial responders, you have 50% of the total number or the size of the previous lesions for more than 4 consecutive weeks, and or flattening of the nodular, 50% of the nodular lesion without occurrence of new mucocutaneous lesions. Okay, so these are the partial responders to the treatment that you've offered based on this protocol. Okay, and then you have the stable disease individuals, and these ones, there's any response not meeting the criteria for progression, which is the next one, and the partial responders. Okay, so now the progression is there's an increase. There's a 25% increase in the number and size of the lesions, and then there's appearance of new mucocutaneous lesions. So now it's like the stable disease are in between. It's like they don't have a response, but at the same time, they might be having a response, but it's not as that one of the partial response. So this is what I was talking about. I think I'll include this when I'm doing for the next group, because it's good to know whether your treatment is actually working or not. Okay. Is that okay, Maria?
Yes, thank you.
So,
Good evening, Doc.
yes, good evening. How are you?
Can you please go back to the table of AIDS clinical trial group classification of poor and the poor risk and the good risk? Is something I want to see clarification there.
Oh, okay. So, this one. This one?
Yes, yes.
So what did you?
So yes. So my clarification is under the systemic illness.
Yeah.
There's this S1 stuff I'm not understanding, and then this I1 stuff I'm not understanding. Can you please talk about it? And yes,
Which? Sorry, which?
Like yes.
Which SO? I'm not saying SO. I have written SO.
Like under systemic illness, you have written SO in bracket 22 months survival.
Okay, sour. Oh, sorry. Yes. So this was just to it's just what they use to back up the information for when they were trying to tell us the survival of a patient if they have any one of these. So if the T is O, which is basically this, okay, the patient has a survival of around 27 months after initial diagnosis. Okay, and then T1 is now 15 months, but that is in itself alone. So it's not in combination of the others. So I think, but that will just be not, let me not say it because that's not science, but yes. So what you find is if you're in this category, you tend to have a better survival in this particular area compared to this particular area. That's basically what they were trying to establish. So you see, it's better to stay for 40 months compared to 13 months based on the CD4 count. So they were just comparing within the same group. That's all it's all about. So when you're writing it, let's say for example, you're trying to tell someone the situation of the patient, or you're trying to classify for your consultant, you can say the patient is TO. Okay, it's unlikely to be TO and the rest. T1, and then you say the CD4 is I0, and then you tell them that they have some B symptoms and some opportunistic infection, so S1. So it's just a nice way of just telling people where are we categorizing this patient. I hope that is now clear.
Thank you, Doc.
Yeah, no problem. Sawa, guys. Are there any other clarifications in the chat? No. None. Okay. Sawa, guys.
Hold
Enjoy
on.
your. Sorry.
Excuse me, Doc. I have a question. Sorry.
Uh-huh.
When you're evaluating, for example, in clinical practice or in a exam setting, and you're assessing for Kaposi sarcoma lesions, the specific place to look is it only the roof of the mouth, or for example, if you're asked how did you assess for Kaposi sarcoma?
For oral examination or for what exactly?
For example, in a long case exam, if you assess the oral mucosa and maybe expose, where else are you supposed to expose to look for the lesions?
So in like, let's say if it's the oral mucosa that you're looking for, then you check the hard palate and you check the gums. That's where you find it if it's the oral mucosa. If it's the respiratory system, it might be very hard for you to exactly delineate where exactly it is from. But in this particular case, now you'll start talking about those, what do you call this? What was the mnemonic for that? Those inspection, palpation, percussion, and auscultation. So when you're talking about palpation, then you'll have reduced tactile fremmeters, and then you'll have reduced vocal fremmeters. You'll have an increased vocal fremmeters in that particular area. And then you'll also have a dullness when you're percussing. And then when you're auscultating to that particular area, then you'll have reduced vesicular breath sounds in that particular region. Especially if there's obstruction, you'll not even hear anything. So that's how you'd go about in terms of the respiratory system. If it is the general examination, then you have to do a very good palpation of all the lymph nodes. So if it's the lymph nodes, you have to go from top to bottom. Okay, especially if you're thinking it's Kaposi, you'll have to do the preauricular, postauricular, the occipital, the precervical collar, as they call it, around the neck. You have to feel for all those, even the submental lymph nodes, the cervical lymph node, the supraclavicular lymph node, especially if it has gone to the stomach, and then the inguinal lymph nodes, as well as the popliteal, especially if most of the time you tend to have a lower extremity tumors. So you have to do a very good palpation of the lymphatic, of the lymph nodes palpation. What else? For the cutaneous, you'll see it. So you'll just try your best to remember how to describe lesions. We talked about it last week, saying whether it's macular, nodular, whether it's a plaque, whether it is scaly. So you have to talk about keratosis. Whether it's wart-like, we talked about the classical. You can have warts. Yeah, so basically being able to give those dermatological terms is a nice way of describing it. And then again, the patient will come with, sorry, the wounds again can also ulcerate. We say that they can be macular, nodular, or ulcerate. And in that particular case, you also have to talk about whether it's bleeding, how much it's bleeding, yeah, and the size and all those things. So basically it's when you're talking about like a long case, when you're talking about the history, you have to give the progression of the illness. There's a mnemonic that we tend to use, but it's not only for Kaposi sarcoma itself, but just symptoms in general. You talk about, it's called operates. So you have, I don't know whether you guys have heard of it before. It's called operates mnemonic. Let me look for it. Where the O is the onset of the illness. You have to talk about the onset of the illness. Again, the reason we're talking about the onset is we want to know whether we are already in stage 4, whether the disease is rapidly progressing. And then you have to talk about the progression of the illness. What has the patient done about it? Okay. What are the factors that are making it get worse? So is this patient immobile? So that means that they'll get lymphedema more what are the relieving factors? Have they been lifting up their limbs? Have they already gotten local excisions? We'll talk about the timing. When does it appear? So in particular case, in this Kaposi sarcoma, you tend to have a consistent or a persistent lesion that does not disappear over time. So the timing is constant. Okay, so they don't have episodes. So the other one is E, which is they don't have episodes free of the symptom. And then now you talk about the systemic inquiry. So in this particular case, they will, if they're in the poor risk region, then they will have what do you call this? They will have the B symptoms, which is fatigue, weight loss, fever, night sweats. That's the stuff that you expect. So when you come to the physical exam, it's what we just talked about, giving those dermatological terms: macular, nodular, ulcerating. That's for the cutaneous. Talking about the size, is it what region of the limb or the site where you're seeing it? How big is it? How much is it affecting? The smell, we talked about smells when we talked about wounds in the first week. And then now when you come into GIT and the oral mucosa that you're talking about, you talk about how does it look like. So we said it's pulp, it looks like a cauliflower or a polypoid nodule in the hard palate, but again you also find it on the gums, right? And then when you're talking about the respiratory system, the IPA, which is inspection, palpation, percussion, and auscultation, have to be described for these particular patients. And then that's basically it. When you talk about the general exam, make sure you talk about the lymph node. The lymph node, is there any lymphadenopathy, and at what particular point, and which ones are affected? Is it the pre-cervical collar? Is it the deep cervical ones? Can you already palpate them? Can you palpate the supraclavicular nodes? And what does that mean in terms of the GIT system? Then the inguinal, the popliteal. So yeah, that's basically how you'd go about it, and then now you see what questions your consultant has for you. I don't know whether I've helped.
You have. Thank you, Doc.